Hi, everyone, and thank you for joining California ACC Prevention Educational Webinar. Tonight, we are joined by Dr. Nathan Wong, Dr. John Baker, and Dr. Nicole Harkin to present on this topic. A few notes before we begin. During this webinar, the chat box will not be monitored. If at any point in time you have a question during the presentation, please put them in the Q&A box. You can find that at the bottom of your screen on the toolbar if you are logging in on a computer. If you are joining us from a mobile device, you can tap your screen and find the Q&A box on your screen. It should be in a little white box. If you feel comfortable doing so, please introduce yourself with your question, as we would enjoy knowing where you are tuning in from. And with that, I will pass the webinar over to Dr. Wong.
Okay, welcome everyone. I would like to thank you all for attending tonight's California ACC Prevention webinar. I'm from the University of California, Irvine, and on behalf of myself and Dr. John Baker, and we both co-chair the California ACC Prevention Committee, like to welcome you all. And we really have a fantastic program in store for you tonight, and I'm going to introduce our speaker and let her proceed. So Dr. Nicole Harkin is a preventive cardiologist. She's board certified in internal medicine, cardiology, echocardiography, as well as clinical lipidology, and she graduated from Boston University magna cum laude and also attended Columbia for internal medicine, and then did her cardiology training at New York University. She's the founder of Whole Heart Cardiology, which is dedicated to private practice and preventive cardiology that provides optimization of treatment through precision and lifestyle medicine. Her practice is based in San Francisco. She's very passionate about prevention of cardiovascular disease using the latest diagnostics, as well as newer therapies and sustainable lifestyle changes. And she works with her patients to create proactive and personalized cardiac care roadmaps for health span and the entire lifespan, and lives with her family in Tiburon, California. So she's going to be speaking tonight on what is a critically important topic that the entire cardiology community needs to embrace, the role of GLP-1 receptor agonists in cardiovascular disease prevention. So take it away, Nicole.
Thank you so much for that introduction. I'm really excited to talk about this topic. I really feel that this is the latest game changer in our arsenal of therapeutics that we can use to prevent cardiovascular disease. So we have a lot to cover, so let's jump in. I want to kind of go through how these came about, sort of the gap that they fill within kind of our prevention world, and then kind of really go through the trial data demonstrating their cardiovascular benefit, go through some other indications briefly, and then I really want to spend a good amount of time on some of the practical topics. I get a lot of questions. I use these all the time in my clinical practice, and I get a lot of questions about utilization, prior authorizations, all those sorts of things. So I want to leave time for those sort of practical notes as well. Okay, so very briefly, as we all know, despite the availability of preventive therapies, cardiovascular events still occur. And so there's really just this concept of residual cardiovascular risk, right? Which is that risk that still persists despite our very best efforts at achieving very low LDL levels, blood pressure control, et cetera. And so we really know that cardiovascular events still occur despite optimal therapy. We see this in statin and other non-statin trials showing that significant cardiovascular risk remains even after we reduce that LDL. In Fourier, we saw that after just a little over 2 years, nearly 6% of patients in the treatment arm still suffered from that composite outcome of cardiovascular cardiovascular death, MI, and stroke, despite getting their LDL below 30 milligrams per deciliter. So this really suggests that there's a need for intensified efforts at both lifestyle as well as treatment strategies to reduce residual risk from other arenas. So inflammation has had its moment. We've talked a lot about it. There's still a lot more to come from that realm. But today, really, we're going to be focusing on this area here with weight management and diabetes. So again, very briefly, some background here. We all see these patients in practice. We're very familiar with them. But in general, type 2 diabetes, obviously very prevalent. About 1 in 10 Americans, unfortunately, has type 2 diabetes. And cardiovascular disease is, of course, the leading cause of death in these individuals. Although glycemic control, and this is the point I really want to bring home, although glycemic control is associated with reductions in the risk of microvascular complications, macrovascular benefits, i.e. cardiovascular outcomes, with tight glycemic control was really less certain. And until recently, reductions in hemoglobin A1C with the use of specific agents didn't necessarily have a clear and reproducible benefit in reducing the incidence of cardiovascular disease. And we saw in several trials that actually there was some signal of harm. And so actually, as a result of this, in 2008, the FDA actually mandated that all new diabetes drugs conduct studies demonstrating cardiovascular safety. And we'll see that this mandate actually is really what led to some really interesting trial data. Obesity, also very, very common. About 40% of the adult population currently lives with obesity. This is predicted to be more than half of the global population by 2033. Obesity and overweight are associated independently with an increased risk of cardiovascular events, even after the influence of metabolic cardiovascular risk factors linked to this excess weight has been accounted for. We also know that it's in our secondary prevention guidelines. Lifestyle interventions, diet, exercise, behavioral changes are really the cornerstone of our treatment for obesity management. But we all know how difficult that is to achieve. And in even the most intense lifestyle interventions, trials show that 80% of weight is expected to be regained over the next 5 years. And so sustainability is a very difficult thing to accomplish. And so we've really had a hole in our ability to help these individuals really reduce this comorbidity, and really also limited evidence that treating it actually reduced hard cardiovascular outcomes, unlike our lipid data and our antihypertensive data. Okay, so GLP-1, what is it? It is in our bodies, it's an incretin, which is a gut-derived hormone, and it plays a really important role in glucose homeostasis. We'll get into it a little bit more exactly how that's accomplished, but I wanted to briefly share the origins of this. It was actually a GLP-1-like peptide, which stands for, by the way, glucagon-like peptide 1 receptor agonist. So this was first found in the saliva of this venomous lizard, and a peptide called exendin 4 was first discovered, which really was found to mimic GLP-1. And it was a little bit longer lasting. So this was sort of ushered in the era of GLP-1 based therapies. We've since created many different agents that are longer and longer lasting with variable effects. So GLP-1 receptor agonists, what really is this mechanism of action? How does this help with diabetes and weight loss? So as I said, endogenous GLP-1 really acts primarily to stimulate the pancreatic beta cells to release insulin. And this really provides a glucose-dependent mechanism to reduce postprandial hyperglycemia. And because it is glucose-dependent, it doesn't result in significant hypoglycemia, which has also been a game changer in the diabetic space. So GLP also really interestingly has multiple different extrapancreatic actions, and there's receptors found on gastric mucosa, kidney, lung, heart, skin, immune cells, and the hypothalamus. And some of these actions also help to, when they act on the stomach, delay and decrease gastric emptying. When acting on the hypothalamus, reduce appetite suppression and suppress appetite. And we're still very much learning some of the impacts of all these different impacts throughout the body. And then, as I said, while endogenous GLP-1 has a very short half-life on the order of minutes, the synthetic GLP-1 receptor agonists that have been created are resistant to degradation. And so some of them allow for daily and then eventually weekly administration. All right, so here is a table of the currently available GLP-1s that have various half-lives, various indications. You can see that very first one, exenatide, that was based on that initial compound that was discovered, was first approved back in 2005. But that was a twice daily injection. Since then, the formulations have had improved sort of delivery systems. So the ones that I've put in the boxes actually have shown cardiovascular risk reduction in RCTs. Only Wegovy, which is the very bottom drug that is a type of semaglutide, actually has a cardiovascular indication for it. We'll go through a couple of these very, very briefly. I do want to highlight liraglutide, which is available as Victoza for a diabetes indication, and Saxenda for weight loss. This was the first one that was really ushered in this era of these potentially being cardiovascular medications. And that one results in a modest weight loss of kind of on the 5 to 8% body weight era, and then about a 1.5% point reduction in hemoglobin A1C. Semaglutide, as many of you are hopefully familiar with, as I said, is available in Wegovy, which is the weight loss indication, and Ozempic for diabetes. On average, it results in about a 12 to 15% body weight reduction and about a 1.8 percentage point drop in hemoglobin A1C. And in the STEP trials, which were the landmark weight loss trials, almost a third of participants actually lost greater than 20% of their body weight, which is really incredible given that about 10 to 15% body weight loss is typically what's recommended to really reverse the cardiometabolic implications associated with excess weight. Okay, briefly also, not only do we have GLP-1 receptor agonist, we also now have a dual incretin agonist, and it is a dual GLP-1 and GIP receptor agonist. And so GIP is just another incretin. It is secreted by cells in the small intestine and binds to specific GIP receptors. These receptors are also found throughout the body, pancreatic beta cells, subcutaneous and visceral adipose tissue, bone, heart, etc. And it is really co-secreted along with GLP-1 and is thought to interact in a very additive fashion and potentiate glucose-induced insulin secretion. So the only available synthetic dual-acting GIP-GLP-1 is tirzepatide, and that's marketed as Mounjaro for the diabetes indication and Zepbound for weight loss. And clinical trials with this agent have really shown a superior weight loss reduction compared to semaglutide, and this actually, they just had another big head-to-head trial. Essentially, as I said, we see about 15 to 16% reduction with semaglutide and about a 20% body weight loss with tirzepatide. We also see superior glucose control as well. Okay, so I wanted to briefly highlight LEADER. This is an RCT looking at liraglutide in patients with ASCVD and type 2 diabetes. So at this time, liraglutide was a once-daily GLP-1. It was approved for the treatment of diabetes in 2010. And this trial really was only designed to meet that FDA mandate in order to get approved, essentially. And so it was initiated in 2010. It was designed for non-inferiority, and really they were just looking to show safety. And lo and behold, it actually demonstrated a significant reduction in a 3-point MACE, cardiovascular mortality, non-fatal MI, non-fatal stroke over close to 4 years, a 13% risk reduction. This was in patients with type 2 diabetes and ASCVD. although it was designed for non-inferiority, this was really, quite interesting and very compelling, particularly since they saw this independent of the individual's baseline LDL and persisted among statin users. Shortly thereafter, a similar trial with semaglutide, which had just sort of come onto the scene as a once-weekly dosing that was in development at that time, but not yet approved for diabetes. And so SUSTAIN 6, again, was similarly designed to for non-inferiority and prove cardiovascular safety. This trial was a multinational placebo-controlled RCT, a little over 3,000 patients who had inadequately controlled type 2 diabetes. Individuals on average had diabetes for almost 14 years. Hemoglobin A1C was 8.7. And then they also had to have ASCVD. Not quite 80% of them were on lipid-lowering medications, but most of them were, fairly on goal-directed medical therapy. And lo and behold, after an average of 2 years of follow-up, we saw a 26% reduction in that same 3-point MACE. It was mostly driven by a 39% reduction in non-fatal stroke, but the study actually, wasn't really powered to detect a difference in the individual endpoints. And unsurprisingly, they saw improvements in hemoglobin A1C, weight reduction, a modest blood pressure reduction as well. And one thing I wanted to highlight is that they actually did see similar risk reductions for this primary outcome and all the components observed for both doses of the semaglutide, both the 0.5 as well as 1 milligram dose. And we'll get into all the dosing later, but I thought that was particularly interesting. As a result of this safety data, it was approved for diabetes in 2017. Then came the SELECT trial. So this is the one I want to spend the most time on. It's our true cardiovascular outcomes trial designed for superiority. After the diabetes indication, the weight loss obviously did not go unnoticed. And so semaglutide sort of became reformulated. The STEP trials were conducted, which really demonstrated effectiveness for weight loss in individuals without diabetes. And so the SELECT trial was really designed to assess cardiovascular implications in a population without diabetes. So this RCT, again, much larger, over 17,000 patients who had BMI greater than 27. They also had to have established cardiovascular disease. Important, this was defined in this trial as prior MI, prior stroke, or peripheral arterial disease. And it was designed to, as I said, assess superiority of once-weekly Wegovy. And this is now at a slightly higher dose. 2.4 was the target dose compared to placebo. And the outcome was this 3-part MACE. Both groups were receiving standard of care, and all the cardiovascular therapies could be adjusted throughout. So in terms of the patient characteristics, really quickly want to highlight while the patients could not have diabetes, obviously on average mostly had pre-diabetes, they had hypertension that was reasonably well controlled, obviously had hyperlipidemia, again, reasonably well controlled, but not quite at goal for individuals with ASCVD, but many of them were obviously on lipid-lowering therapies. And then here was the outcome. So we had a 20% composite MACE, so composite of death from cardiovascular cause, non-fatal MI, non-fatal stroke. And as a result of this, this particular formulation of semaglutide was approved by the FDA in March of last year for the reduction of cardiovascular events in individuals with cardiovascular disease and overweight or obesity. Also really interesting, I want to highlight is this really early separation of the curve. That, was really interesting to a lot of people that divergence occurred really early on. And so just wanted to kind of highlight some of the cardiometabolic improvements that we saw. Obviously some body weight reduction, a little bit less than had been seen in the STEP trials, but a 9% body weight reduction. some reductions in hemoglobin A1C, modest blood pressure reductions, modest lipid reductions, a little bit better from triglycerides, again, not surprisingly, given the weight loss. And then really interesting, a really profound drop in the high sensitivity CRP, really driving home the concept that this excess ectopic and visceral adipose tissue really may be contributing to atherosclerosis due to pro-inflammatory and prothrombotic pathways. Okay, the SOUL trial, I want to comment on this. I think this is the last trial regarding semaglutide, but this was just presented as a late breaker in ACC this year. And this is looking at a different type of semaglutide. It's an oral formulation. This is marketed as Rybelsus. It was approved in 2019 for diabetes, and but didn't have a lot of data in terms of cardiovascular outcomes yet. The safety had been established, again, as per that mandate, but they really now wanted to look for efficacy. And this is important because, studies have really shown that patients do tend to have a preference for orals over injectables, and so providing additional optionality here. And so this was a trial of just under 10,000 patients. They had to have type 2 diabetes and either ASCVD or CKD. They were started on Rybelsus and titrated up to about a 14 milligram dose. And again, the primary outcome was this 3-point MACE, and they saw a 14% risk reduction compared to placebo. And there was really no new safety signals that were seen either. So this formulation, they actually, my understanding is they've submitted a label extension for CV event risk reduction to the FDA. So we'll stay tuned for that. But currently available for just individuals with diabetes. Okay, so beyond ASCVD, I want to briefly touch on a couple of other topics that are really interesting: HFpEF, CKD, sleep apnea, fatty liver. I don't have time to cover all of these. The data on this the number of trials on this topic is just overwhelming. But close to our heart as cardiologists, HFpEF, we know that heart failure with preserved ejection fraction is increasing in prevalence. It is associated with a very high symptom burden, very common in individuals with obesity, and we still have, fairly limited therapeutic options. And so this was an interesting trial with semaglutide in patients who had obesity and HFpEF, very small, a little over 500 patients. Their BMI had to be greater than 30. And they found that actually semaglutide was superior to placebo in obviously reducing body weight, but also in some patient-oriented quality of life outcomes and 6-minute walk distance and those sorts of things. And it was underpowered for heart failure clinical events, although in an exploratory analysis, they did see that there were heart failure hospitalizations that seemed to be reduced. So only one patient in the semaglutide group versus 12 in the placebo had an adjudicated event of hospitalization for heart failure or an urgent care visit. One major limitation of this trial that I just want to highlight is that very few of them were on SGLT2s, however. Interestingly, tirzepatide, which we haven't had a chance to talk about yet because some of the trials are still ongoing, this trial was published just the end of last year, looking at a very similar patient population, HFpEF with obesity, and had a very similar inclusion criteria. They did require that the patients have had a fairly recent, over the last year, heart failure decompensation. They had a 2 primary endpoint composite of CV death or worsening heart failure event, and then also, similarly looking at symptoms. And they found that there was a significant reduction in this composite event by 38%, and it was primarily actually driven by a reduction in heart failure events. Again, only other limitation with this trial as well, similarly very few on SGLT2s, only about 17% at baseline. So wanted to briefly highlight this, given that SGLT2s have really emerged as a first-line agent in heart failure guidelines, irrespective of diabetic status. So really sort of a question has come up, is that given not many patients were on SGLT2s in those prior trials, what is the role, additional additive benefit of GLP-1s? This is a retrospective sort of chart review observational cohort of over 30,000 patients, or almost 30,000 patients. With type 2 diabetes, a BMI greater than 27 and HFpEF, and they were all on SGLT2s, and then they compared them to a well-matched group of individuals who also were on GLP-1s. And really they found that over this 12-month follow-up, the group that was on both agents did have a lower risk of all the composite, of all the outcomes that they studied, which you can see in this table here, including heart failure exacerbations and hospitalizations, as well as all-cause mortality. And they really saw this benefit across all the subgroups of EF and BMI, really suggesting that there is an additive benefit of the GLPs on top of SGLT2s. Flow, again, very briefly want to highlight the CKD data. So this is semaglutide in patients who have CKD and type 2 diabetes. Interestingly, only about 23% of this population had had a prior MI or CVA, but most of these patients, again, all had CKD and type 2 diabetes. Most of them were obese. The average BMI was 32, they were given semaglutide up to 1 milligrams. And the primary endpoint was a major kidney disease event, but they defined that as composite of new onset kidney failure, initiation of dialysis, and then death from kidney-related or cardiovascular causes. And this trial was actually terminated early due to efficacy, and it reduced that composite outcome by 24%. And then the individual endpoints, secondary endpoints, cardiovascular mortality was significantly reduced as well. And they saw this across a very broad range of CKD severity. So this will be really interesting to see sort of what happens here as well. Oh, and then the last one, there's so many, I'm telling you guys. SURMOUNT-OSA, this is a trial looking at actually tirzepatide. I wanted to highlight this because actually tirzepatide does now, as of December 2024, have an FDA approval for, and it's the first ever medication actually that's ever been approved for the treatment of OSA. So it's approved for the treatment of moderate to severe sleep apnea in adults with obesity. That was based on this trial, patients who had moderate to severe OSA and obesity. There was 2 different arms, and so one trial, the patients were on CPAP. The other one, they were actually intolerant of CPAP, and they found significant reductions in the AHI, which is the number of apneas and hypopneas that occur in 1 hour. In both arms. And actually 50% of the patients that were in the tirzepatide arm actually had resolution of sleep apnea entirely. So, so this is also a current indication that you can try to get tirzepatide approved for, which is really exciting as well. Okay, so these trials are all really quite new, but I did want to at least touch on what our current guidelines say with regards to these agents. So first, looking at the secondary this CAD population, so the coronary population, patients who do have coronary artery disease and are overweight or obese, in whom you feel that pharmacotherapy is warranted for further weight reduction. Even in these guidelines, they do suggest a GLP-1 receptor agonist in addition to obviously diet and physical activity, and that it would be reasonable to choose semaglutide for its cardiovascular benefits. Looking at the management of diabetes in patients with stable coronary disease, our guidelines currently suggest either an SGLT2 or a GLP-1 receptor agonist with proven cardiovascular benefit to reduce the risk of MACE. The American Diabetes Association, their guidelines are a little bit more recent, so they recommend that in all patients with type 2 diabetes who have coronary artery disease or CKD, they should receive an SGLT2 or a GLP-1 with cardiovascular benefit as part of, and I like this language, a comprehensive cardiovascular risk reduction and or glucose lowering treatment plans. So really highlighting kind of the cardiovascular benefits here. I also thought it was interesting that they comment that in patients that have type 2 diabetes and established ASCVD or multiple risk factors for ASCVD, that a combination therapy of SGLT2 with benefit, GLP-1 or receptor agonist with benefit could be considered for additive reduction of the risk of adverse cardiovascular and kidney events. And then our heart failure guidelines, currently mostly calling out SGLT2s is for HFpEF population to decrease heart failure hospitalizations and cardiovascular mortality. There was an updated expert consensus decision pathway in HFpEF in 2023, which did say that in individuals with HFpEF and obesity, a GLP could be considered if they have obesity and diabetes and HFpEF. Okay, the fun part, practical considerations. How do we figure out which drugs to use, how to titrate them, what are the common side effects, and what's some troubleshooting? How do we get these approved? Okay, so first of all, this can get fairly confusing, but it's really important to know which sort of branded version you want to prescribe for which indication. That's the number one piece of advice I can give you for trying to make sure that you can get coverage for your patients who need these drugs. So for semaglutide, it's marketed as Ozempic, and this is for the diabetes indication, and Wegovy, which is for the overweight or obesity indication. So starting with Ozempic, if your patient has diabetes, always choose Ozempic. This is the easiest one to, it's recognized by all major payers as an indication for diabetes. And so I've really never had problems in my patients who have diabetes getting this approved. So always start there. And remember, obviously diabetes is defined as having a hemoglobin A1C greater than 6.5, but don't forget about some of your other parameters. So any random glucose greater than 200, or think about even an oral glucose tolerance test. Oftentimes those will become abnormal first. And so if that's greater than 200 as in the 2-hour postprandial, that is the gold standard for diagnosing diabetes, and you can code it as such. The dosing for this one is 0.25 and 0.5 as the starting doses, and then you ramp it up accordingly. Important to note, and this is different between the two, and so you want to just kind of highlight that for your patient. The Ozempic is actually a reusable pen, and it comes with several needles. So that starting pen will contain 2 milligrams of Ozempic, and it's going to give them a handful of needles, and they just change the needle out each time. So it will give they'll get 4 needles for the 0.25 milligrams, and then they actually have to crank it, and it'll change the dose to the 0.5, and then they can administer the 0.5 for 4 weeks, and then thereafter is when you'll have to give them a new prescription. And then you escalate to 1 milligrams and or 2 milligrams, depending on, and we'll kind of get into some of those factors, but how they're tolerating it, et cetera. The Wegovy is actually is different. So again, remember this is for overweight or obesity. And then this is the one that has the cardiovascular outcomes indication. So if your patient has established cardiovascular disease, and again, they are very, very picky on this, unlike some of our other agents, they have to have had a documented prior MI, prior CVA, or have peripheral arterial disease, as well as a BMI greater than 27. Documentation, documentation, documentation. So if they truly meet, and it's not just stent, like they have to have had a heart attack. So if you have that documentation, then you can usually get a prescription for Wegovy. Keep in mind, if they don't meet that strict criteria and your patient does not have weight loss benefits, then you will often get denied. The Wegovy's are a single-use pen, and so the dosing is pretty similar to STIRT, and then just keep in mind that last couple doses is 1.7 and 2.4. And these are all, as I said, single-use pens, so they use it and then they toss it. So you do need to give them a new prescription for each one. I happen to have one of the pens right here, and essentially, well, this is obviously a sample. Really, it's just very similar to kind of it's the SureClick technology, and they just remove the cap. There's no real needle that they even see, and then they would just administer it here. They'll hear a click, and then they'll start to see the yellow line going down, and then once the yellow line's done and they hear the second click, then they're done. So it's really very straightforward. I recommend getting one of these demo pens so you can show people. People are still, nervous about injectables. I even, I have a practice one for my PCSK9 inhibitors as well. Okay, tirzepatide, again, this does not yet have a cardiovascular indication, but it does have superior weight loss. And so for individuals who have not gotten to goal weight or plateau very early on semaglutide, you can make the judgment call as to whether or not you feel like they might benefit from tirzepatide. It doesn't currently have a cardiovascular indication, but that would have to be a judgment call. I use it quite a bit in my practice as well. For if they have type 2 diabetes, again, always prescribe the Mounjaro. If they don't, then Zepbound would be the drug that you would prescribe. I have not yet gotten approved for sleep apnea, although I have a colleague who has, so we'll see how that's a relatively new indication. The most recent insurance company we submitted that to said that it was not yet an approved indication. So TBD there. The dosing here is a bit easier. It's the same for both. You start at 2.5 and then work your way up to a max of 15. And again, it's every 4 weeks that you dose escalate. Okay, so the dosing. My biggest piece of advice would be to start low and go slow. Again, even though the protocols say that you would start at each dose at 4 weeks and then ramp up by 4 weeks, you do not have to follow that protocol necessarily. And so this is a marathon, not a sprint. The goal is not to get them to goal as quickly as possible. For the most part, you really want to get them to be able to tolerate these medications. And if you go too fast and persist and keep dose escalating, even though they're having significant GI distress, they might not be able to tolerate the medications altogether. So if your patients, so the most common side effects, of course, are GI related. Nausea and diarrhea by far are the most common symptoms you'll experience. Most people do have a little bit of nausea. If they're having significant GI symptoms, I do delay my dose escalation until they're able to tolerate it. And some patients don't, and they really stay on one of the lower doses, and that's really all they can tolerate. But they get to goals. Certainly provide advice to limit nausea in terms of frequent small meals. Some people actually forget to eat a lot, and that makes them nauseous. So focusing on fiber and protein and frequent small meals, not eating right before bed, hydrating, and moving. Another tidbit, I would definitely keep an eye on blood pressure. Many of my patients have had to have been able to come off blood pressure medications pretty early on. So just keep an eye on that within the first couple of months of therapy. And I do try to meet with my patients as frequently as possible, talk through side effects, problem solve, et cetera. Really improves adherence. Okay, so what are the contraindications? These agents are for individuals with type 2 diabetes, not type 1 diabetes. I do have a handful of patients who I share with endocrinologists and so some endocrinologists are using this for weight loss in their type 1 diabetics. I'm going to leave that to the endocrinologist, so it is a contraindication. Pancreatitis is technically a contraindication, although really this hasn't been seen as a complication of any of these trials that I kind of went through. But technically, if a patient has had pancreatitis, these agents shouldn't be used. And if they have pancreatitis when on them, you should stop immediately and not restart. Gastroparesis, really rare side effect of the medication, but if a patient has it at baseline, not a great agent for them either. And then personal or family history of medullary thyroid cancer or MEN2. This is really, again, only something that was seen actually in the preclinical trials, but remains a contraindication nonetheless. Keep in mind, medullary thyroid cancer is not the most common type of thyroid cancer. And so if your patient has had papillary thyroid cancer, for instance, they theoretically could still utilize these agents. Okay, side effects. We talked about gastrointestinal symptoms, again, incredibly common. They're very dose dependent and they're typically transient. And so again, just they can improve over time. So slowly titrate if you need to. So I've even had to dose reduce and had resolution of symptoms, and then you can kind of up titrate. And this nausea happens, with both of these agents pretty equally, anywhere from 17 to 22% in the trials. Discontinuation rates in the trials are anywhere from 7 to 9% because of GI effects. Importantly, because these agents delay gastric emptying, you really need to hold them a week prior to a procedure or a surgery. And your anesthesiology colleagues will thank you. You don't actually need to hold them if they're fasting, however, because they're really not hypoglycemic agents. We talked about pancreatitis. Oh, diabetic retinopathy. So this is actually seen not uncommonly with rapid glucose normalization or improvement. And so if you have a patient who's had long-standing diabetes and or is known to have diabetic retinopathy at baseline or other diabetic complications, definitely make sure they're plugged into their eye docs before going on these medications. It usually is transient and self-resolves, but it has been seen and it's not unique to these agents. Hypoglycemia, we've talked about, it really does not happen unless they're on insulin secretagogues, insulin, et cetera, in isolation. It really does not seem to happen. Increased heart rate. It's interesting. They were really worried about this at first in some of the trials, and you'll see it does increase by a couple beats per minute. Resting heart rate obviously has not had cardiovascular impact given our outcome trials. Muscle loss. This is what I wanted to also focus on. So this is really important. When individuals lose weight by any mechanism, there is some muscle mass loss that is also lost along with adipose tissue. And with the GLP-1 receptor agonists, the fat-free mass decreases anywhere from 25 to 39%. And this is compared to something like 10 to 30% that's seen with non-pharmacologic sort of caloric restriction. It's really not thought to be, again, an actually specific to these medications, but just more of attributed to kind of the magnitude of weight loss rather than an independent effect. Most importantly, how can we help our patients in this arena? And there's been a lot of interesting work looking at this. One of the biggest recommendations would be sort of the protein intake. And so there was a recent study looking at individuals who were losing weight via energy deficits, and they were recommended to consume twice the RDA of protein, which really preserved fat-free mass during weight loss better than much lower intakes of protein in the order of 0.8 grams per kilo, which is the current RDA. So you can recommend anywhere from 1 to 1.6 grams per kilo in your patients of protein. I think it's simpler to think in terms of grams per meal. So 30 grams per meal is a great sort of place to start. And that's, kind of consistent with maximum stimulation of muscle protein synthesis anyway. And I have, spread it throughout the day, plan around sort of high quality protein, and don't be afraid to use protein powders. Again, many individuals on these agents are just not that hungry. And so that can be a great way to kind of supplement. In addition, resistance training. I know we're always talking about, aerobic exercise, obviously, as cardiologists, but this is a time to really emphasize the importance of resistance training as well. And so I'll typically recommend at least 2 sessions per week, along with their 150 minutes of moderate intensity aerobic exercise. And they can really start with body weight exercises or resistant bands if they're just if they're untrained. And again, this is another place to consider slower dose titration if you're worried about muscle loss. Okay, another very common question we get is, can I stop the medications? So in general, the answer is, at least at this time, no. Just like your glasses, your statins, your blood pressure medications, when you stop using them, unfortunately, the effect begins to go away or goes away immediately. And weight loss is really interesting. There's a lot of compensatory biologic changes that actually prevent the maintenance of weight long-term to begin with, which is partially why weight regain using non-pharmacologic means is so common. And so this question was looked at in a number of different ways. I'm showing you 2 different trials from step 4, which was the weight maintenance trial, and then the step 1 kind of extension phase. And in both these trials, essentially, when individuals switched over to placebo, they no longer continued to have weight loss, unlike if they were to continue semaglutide. In the step 1 extension, which was an observational study of a subset of the original step 1 group, 1 year after stopping the medication, they actually had regained approximately 2/3 of the weight that they had lost during treatment. And so there can be, a couple of different strategies here, and I think that this is a really evolving area as to what is going to happen in the terms of weight maintenance. I do have some folks who, after a couple of years, have spaced out their medications, and so they're injecting kind of twice a month, and they have found that has worked well for them to kind of maintain their cardiometabolic gains. Okay, surviving the prior authorization and coverage concerns. Again, pick the right drug for the right indication for your patient. Keep in mind that for that cardiovascular indication, they really have to have had, as I said, an MI, CVA, or have PAD. And again, as I said, if they don't have weight loss benefits, then your hands may be tied. Documentation is really important, as it is with all of those, all of our medications where we have to obtain PAs. These are some of the things that you can kind of think about. Some of the insurance companies will still require that for weight loss approval, documentation of a patient sustaining in a caloric deficit for more than 3 or 6 months, as well as dedicated exercise therapeutic plans. So make sure that those are in your notes, as well as obviously the exact BMI, any weight-related comorbidities, etc. Okay, compounded. So for a very long time, as I'm sure many of you encountered, these agents were not available. There was drug shortages. It was really difficult. So many compounding pharmacies started making these medications. And there has been significant number of adverse events that have been reported, some requiring hospitalization. Usually it's related to sort of dosing errors and things like that. But at this point in time, it's sort of a moot point. As of February of this year, the semaglutide drug shortage is quote unquote resolved. And really starting in May, they're going to start enforcing this. So my advice, don't do this. That said, if your patients, so you go through the whole process, they do not have weight loss benefits, they don't have diabetes, and they don't have ASCVD as defined by their criteria, if you get denied, it's still not necessarily affordable, but it is actually a lot better than it used to be in terms of cash pay options. And so you can actually directly prescribe these medications to the manufacturer direct pharmacies. So in the case of Wegovy, in your EMR, you'll put in NovoCare, and in the case of Zepbound, you'll put in LillyDirect, and they'll deliver it straight to your patient. So you just send it through your EMR like you would to any other pharmacy. They'll email the patient to set set up an account. And here, these are the kind of set prices. This is dramatically different than it was even a few months ago. And so for Wegovy, this is the pricing per month. Again, still very, very expensive, but much better than it used to be. Of note, Zepbound, it's still, and this is how some of these used to be, but Zepbound still is in a vial, so for the direct care option. So just know that, so your patient's not surprised that it comes in a vial and a syringe that they provide, and they actually have to pull it up and inject. I was really shocked that none of my patients have really had issues with that, but just know that. Okay, a couple quick patient examples. We're really running out of time, so I want to fly through these. I just want to emphasize a couple of quick patients. So this is a patient who I saw, have seen. You have him in your clinic too, premature coronary artery disease, used to smoke, has prediabetes, hypertension, hyperlipidemia, all the things. His other comorbidities very well managed, but really has struggled over the years with insulin resistance, metabolic syndrome, obesity, and that's his main residual risk factors. PCP has really tried to help him lose weight. Since seeing me, we've developed this dedicated program. He sees an RD, he sees a trainer. He's really been trying hard, but despite that, he just really, endorses that if he goes to a restaurant and his plate is there, he feels the need to finish it. He'll snack on nuts, which is what the RD has recommended, but then he'll finish the entire bin. So this has been a persistent problem for him for some time. As you can see, before starting semaglutide, blood pressure was good, lipids were pretty good, but he had pre-diabetes and such. And when we started him on semaglutide and up titrated him to his max dose, he lost, significant abdominal adiposity. His genes were, several sizes down. His BMI was, as you can see here, very close to normal. And most importantly, and this will not happen when you prescribe your statins ever, he was just so, I feel like for the first time in my whole life, I have a relationship with food that I feel like everybody else does. I mean, just more patients than I can ever express are just so incredibly grateful to you and just feel like it has really impacted their lives in dramatic ways. And so it's really rewarding to really feel like we finally have something to offer for patients that have just really struggled with this in an immense way for years and years and years. Prediabetes resolved. His lipids are even more beautiful. I mean, we're all happy campers. Oh, and this is one of the guys that I did. He was pretty dizzy after just like a month or so, and stopped his chlorothalidone. And so that's another thing that you can tell patients, and this is actually relevant for the next patient. So there's kind of patients who are obviously interested in these agents, and then there's patients like this guy who came to me after a fresh stent and for optimization, he was not excited about the GLPs, and so we really had got him on Repatha and rehab, cardio rehab, and really wanted to try to not take a weight loss medication. It took me basically an entire year almost to finally convince him to think about this. We went through the cardiovascular data, and he is now, I don't have repeat labs for him on these agents yet, but he's doing great and he's so excited and, feeling great. So lots of different types of patients you'll encounter, but hopefully that gives you a little bit of a window. Very quickly, oh my gosh, we're so over. Trials in the pipeline. These are two really important ones with tirzepatide of note. One is going to be an outcomes trial in patients with diabetes. One, which I'm excited for, is primary prevention. And then we've got lots of trials in the pipeline for, expanding therapeutic scope beyond metabolic disease. There's a trial ongoing looking at Alzheimer's disease. There's other agents in development that are even more powerful in terms of weight loss and cardiometabolic benefits. There's going to be oral agents that are also better than the ones we currently have. So keep your eye on this space. Very final takeaways. hopefully I've convinced you that these are cardiovascular drugs. You should, as a cardiologist, feel very comfortable prescribing them in the same way you do your medications for lipid lowering and antihypertensive and all the things. Consider them, using them in any of your patients with established cardiovascular disease, or I would argue high risk, or have and have diabetes or are overweight or obese. Also think about them in your HFpEF population. Please always prescribe them with a comprehensive lifestyle management strategy. Studies show time and time again, more weight loss is achieved and it's sustained better with this comprehensive strategy. Go slow to minimize GI side effects and really keep your eye in the space. We're going to have expanding indications. There'll be additional agents. This is a whole new world.
Well, thank you so much, Dr. Harkin, for such a comprehensive and well done talk on this very important topic that and therapy that really all cardiologists really, I think, need to embrace as a cardiovascular drug, right, and not think of it as just a diabetes or an obesity drug. So. We have a few questions in the chat. I know one of you was interested as to whether you could download the slides. I do know that this is being recorded, but I guess I would suggest that you reach out directly to actually Dr. Harkin if you are interested in having the slides. The other so let me just ask one thing. So we know that these therapies are still terribly underutilized, right? A lot of cardiologists are seeing patients who have obesity or diabetes, but they're, maybe not thinking of these. And we have gotten approval to actually implement a best practice advisory for these therapies in our higher risk patients with diabetes. That's going to be a while before that gets off the ground because, as some of you know, Epic is undergoing, like a refresh. So they want to wait until that's the case. But I'm just curious what your thoughts are about the best ways you think we can remind our cardiologists of the eligible patients. Are there systems approaches or or other ways, Epic Chat perhaps? I wanted your thoughts on that because
Yeah,
we just
I think
really need to get better uptake of these in our eligible patients.
Yeah, no, I think that's a great question, certainly, and I think it'll obviously depend on the system and the area of care and resources and all sorts of things. But I think just as we saw with any agents beyond statins, for instance, unfortunately, a lot of it is time, right? That the dispersing from the literature, the landmark trials, to really getting into the population. I think it's a tough one, but I agree. You know, Similar to sort of the different checks and balances in EMRs that we have, anytime you're discharging a patient with an MI or HFpEF or reduced ejection fraction or what have you, the different, did you think about, could you, blah, blah, blah. So I agree. I think uptake is a problem. Continuing educational seminars like this, really, this needs to be at the forefront of all of our major cardiovascular meetings, reminding cardiologists that this is in our purview now. It really is.
Yeah. So we have a few questions in the chat. The first one here is when should this be added to metformin? And I know you covered some of the guidelines, and many of them have, really said that you can, you can prescribe these independently of whether or not the person is on metformin, right? They don't need to go through metformin, but curious as to your opinion and kind of your
Yeah, I mean,
practice.
Right. I am, I still use a lot of metformin in my practice. I would say that, certainly metformin only has a fairly modest weight loss benefit. And so it's not even, if you up titrate it to the full max dose, the 2 grams a day, you can get, a 5 to 10 pound weight loss, but it's nothing like what we're seeing here. Obviously it has, it's good for patients who have pre-diabetes and things like that, but um, uh, I am increasingly skipping over metformin, particularly in my patients with ASCVD, and really jumping straight to the GLPs, particularly if they have true diabetes or are overweight or obese.
Great. And I think Dr. Baker had wanted to make some comments about that question as well. Thank you, Nicole. Dr. Baker?
Sure. Yes.
Yeah.
No, I think this, Dr. Harkin, this is an excellent presentation. I think you've covered this area completely. On the topic of patients who have morbid obesity, do you have any differences in how you treat them? Initial doses, meaning that do you get them to a certain BMI, and you, or what is your expectation of the goals of therapy for patients, or is it just as much weight loss as you can tolerate?
Yeah, so if they're depending on which agent you're choosing, you can sort of have a ballpark idea of what you might be able to realistically accomplish with that agent. As I said, I'll typically start with semaglutide. It has the cardiovascular outcome data behind it. But I do, if I have a patient who is I know is going to need, a fair amount of weight loss to achieve their as close to their goal as possible, I do use tirzepatide. Sometimes I'm stepping from one to the other, and then sometimes I am going straight to the tirzepatide depending on the patient, and obviously comorbidities and things like that. And then usually I am up titrating, as was done in the trials, to a maximally tolerated dose, and try to get them to sort of a relatively high dose. That said, for some of my patients who, you know, want to sort of stop in the middle ground because they've achieved their ideal body weight and we're in a good place, I stop. I don't necessarily, feel the need to go all the way up as far as I can. I don't know that we, clearly have that data in comparison to say, heart failure with reduced ejection fraction, you got to get that beta blocker up as high as you can.
Yeah, and I might also comment that for actually morbid obesity, there's even actually triple agonists that are in development, GIP, GLP, and glucagon receptor agonists, and these have early data suggesting even more, like 25% average weight reduction. So they're probably going to be indicated more for for the morbidly obese individuals. So let's see, there was also a question, are there any studies in progress to answer a very important question about how much of these clinical endpoint benefits, like, how much of the cardiovascular reduction might be attributed to weight loss alone, as opposed to, say, some of the cardiovascular risk factor benefits, which we know these therapies have. Do we know of any such studies?
I'm not aware of any studies. I don't know if either of you are. I mean, I think it would be quite difficult to disentangle that it's a rather, I think it's probably, multifactorial certainly. And obviously a lot of the cardiometabolic benefits of weight loss are due to sort of that traditional risk factor reductions. But as I said, I think, many of us are really interested in this concept of the actual adipose tissue itself being inflammatory. And when you reduce the visceral adipose tissue, or reduce the ectopic fat, you really see cardiometabolic benefit. There was a trial with tirzepatide looking at that I'd have to pull up, looking at percent of so looking at sort of epicardial adipose fat, right, and reductions using these agents. But I'm not aware of any trials that have really specifically attempted to try to disentangle the exact mechanism of benefit.
Yeah, I think you're absolutely right, because certainly with weight loss, we're getting improvements in HDL, we're getting reductions in LDL, reductions in blood pressure, reductions in HSCRP. So it's hard to separate that out, but certainly perhaps a post hoc analysis of the SELECT trial maybe should look at that, and I would be surprised if no one has suggested that they do that, and maybe we
Sure,
should.
someone will. We'll
Yeah,
do it.
yeah. So
Yeah, and I mean, I think it'll be interesting because certainly a question I get in my office, and I have a very, specific set of people, but, I think increasingly people are wondering, again, what are these additional benefits? Who stands to potentially benefit from these agents? Do normal weight individuals benefit? I mean, I think that Alzheimer's trial, for instance, will be really interesting. Are there other sort of off-target benefits up for grabs?
yeah. So there was another question. Should this be added to a patient with a high coronary calcium score? And it reminds me of a study recently published by Alex Rizavi and colleagues from Emory, where they applied the SELECT trial eligibility and results to actually coronary calcium scores in the MESA study. And what they found was that the people who benefited most in terms of a very favorable number needed to treat were those with a calcium score of 300 or higher. And and we know that, that of course identifies people at high cardiovascular risk, right? So the same relative risk benefit is going to result in a much greater absolute risk benefit and favorable number needed to treat. But from a practical standpoint, how would you, or how do you apply this in practice, right? I don't think we would necessarily tell a patient who has a 0 calcium score that they won't benefit, right? Maybe they won't benefit as much in terms of cardiovascular risk reduction, but clearly, many of the other factors, including weight, would benefit, right?
Right, absolutely. So obviously there's the non-cardiometabolic effects of excess adiposity, right? The orthopedic, the reflux, all these other things, right? But yeah, I think really at the crux of this is that in general, we know as a cardiovascular community that individuals who have very elevated coronary artery calcium scores are of, equivalent risk to individuals who have had a cardiovascular event. And so in my practice, I treat them very similarly. And unfortunately, as I said, they're not eligible. So if your coronary artery calcium score is 1,000, I can get you on pretty much everything else that's indicated for secondary prevention, but I'm not yet able to initiate a GLP-1 for that cardiovascular outcome indication.
Yeah.
So
the
those are
insurers still aren't taking
no, they are
it.
not. Unlike Repatha, like, a
Oh,
lot of our other
interesting.
agents, they're recognizing CAC greater than 300. They so far have been very, very strict on the prior MI, CVA or PAD indication. And so I think that's the population that's most frustrating right now because they meet criteria, they would most certainly benefit. But so that's why I think that upcoming tirzepatide trial for the primary prevention population will be really helpful to us.
Great. And we had a very nice comment from actually Dr. Irving Lowe, who many of us know. So he pointed out that an AI-enabled clinical decision support system will help clinicians identify the optimal patient suitable for GLP-1 or SGLT2 and pointed out that it's likely a class effect for cardiovascular benefits, and that multimodal GLP-1s may have greater promise, and oral agents may enhance compliance. Although, of course, with an oral agent, you have to take it every day. So what are your thoughts about that? And do we have any evidence that the actually oral agents might be better adhered to? We, of course, we do know, comparing, the recent trial with, for example, comparing with Sustain 6, that, it's somewhat less effective, right, in the oral formulation in terms of cardiovascular event reduction. So I'm just curious about your comments, oral versus subcutaneous injection, less frequent, but maybe, what are your thoughts on that?
Yeah, I mean, I think it might be patient to patient specific. And so I think just optionality will be really helpful there. Just extrapolating from my experience with patients looking at lipid lowering agents, some are really excited about the idea of PCSK9 inhibitors that enable, twice a month injections, or even now twice a year injections, compared to kind of the daily statin that they feel like they're going to forget. So I think that there is, whereas other patients, it makes them a little bit nervous to use an injectable. I'm only aware of the data that I had sort of mentioned, looking at survey data, that, in general, when queried, patients have a general preference for an oral agent as opposed to an injectable. But I think when you posit it, sort of less frequent but injectable versus daily oral, I think you'll have patient populations, different patient populations make sort of different decisions there.
Yeah, and there's been some discussion around tolerability, that perhaps subcutaneous formulations may be better tolerated. Do you know anything about that?
I would say definitely compliance for sure. So with the Ribelsis, you have to take it with water on an empty stomach first thing in the morning. And I think that is a compliance issue, certainly, because that's just a bit more difficult than an injectable that you can choose to do whenever you want.
Great. So we're little bit over time, but just wondering if actually Dr. Baker had any other comments or perhaps questions.
No other comments other than Dr. Harkin. This was an outstanding presentation of a very complex topic that is near and dear to all of our hearts and all of our patients. So I congratulate you on such a well done performance. Thank you very much for preparing these slides.
Right. And I echo that. Really, really amazing talk, Dr. Harkin, and really appreciate all your insight, and hopefully what you've spoken on tonight will motivate our actually cardiology community to really think of these therapies as an important part of their armamentarium to optimize patients' risk. So thank you again, and thank you all for attending and staying on to the end.
Yep, and thank you very much. And I guess this will be recorded. If you have any colleagues that have missed part of the webinar, it's going to be on the California ACC website, so it'll be up in probably about 5 days. So you can check on it there, and it should be available. Our next webinar is in June 11th, which is the second Wednesday of each month, and hope to see you there.
Yeah. Thank you very much. Take care.
Thank you.
Okay. Bye.